So Linda earlier described a lot of the work that we've done around payment reform and around shared savings in particular. We'd welcome the opportunity to work with you on programs that you might be implementing or dealing with in your own lives. We can help with the design and negotiation of shared savings models. We've represented providers, for example, in shared savings negotiations with health plans, and we've worked with health plans to help them design shared savings programs that would work for their provider networks. As I've said, these programs have to work for both constituencies, health plans and providers and patients. And so we really are striving in all these programs to find that win-win formula where everybody has a fair opportunity to achieve a good result. We've done a lot of research for clients on the impact of existing payment models on providers, on their revenues, on patient care patterns, and we've done this research both specifically to existing programs like the CMS program, various PCMH and ACO initiatives around the country, as well as those that are in development. As part of that process, we do build financial models and simulations that help to test different scenarios under shared savings programs. And as Linda mentioned, and as I pointed out in my remarks, linking shared savings to performance measures is really critically important if you want a program that makes sense. And we've worked with a number of clients to help them select from the menu of available performance measures to align those measures with the goals of their programs. So at this point, we're happy to take questions. As Linda mentioned earlier, we'd ask that you submit the questions via the questions function that's in the webinar control panel. And I'll turn it over to Linda to ask if we have received any questions.
Okay, Guy, I have one question here, which is you mentioned that some methods are resource intensive to administer. What makes a method resource intensive?
So I think there are three ways that one method might be more resource intensive than another. The first way is that if it places large data collection burdens on either the provider organization or the payer. Right? So what data do you need to power or drive a program? And what are the costs associated with collecting and analyzing that data? So that would be the first possible source of a resource burden for a shared savings program. Another source would be, what are the internal administrative structures and processes that you need to administer a program? So some of the methodologies that I've described are more mathematically complex, and therefore they just require some more bandwidth, some more brain power in order to implement them. So have you budgeted adequately for that? There are other issues with shared savings programs that also drive resource consumption. For example, how frequently do you do the calculations? If you do it more frequently, you're going to need more resources to do that. We didn't really get into those issues in the webinar today. And then the third driver of sort of resource consumption would be how burdensome is a program how burdensome is it to explain that program to the various constituencies, which typically means provider organizations, and work out the contracting mechanisms that are necessary to implement the program. Right? So health plans have, they have provider network staff who are out in the field working with providers to negotiate and update contracts. Those contracts are already very complex, and so adding new complexity into them is going to lengthen that contracting process. It's going to require more education, and so you just need to strike the appropriate balance there and try to explain as clearly as possible to providers what it is that you're trying to achieve with these programs.
Okay, thank you. The next question is, can you compensate for small sample size by extending the time frame? There's no more explanation of that. I assume that means for like more than a year, or?
Yes, I don't recommend it. Although I'd have to actually, off the top of my head, and that's why I'm sort of thinking this through. I think you might see some small amount of benefit in terms of random volatility if you did extend the time frame. So that is, an individual patient who was unlucky in 1 year might be then lucky in the next year. If you treat each of those as a separate observation, you effectively increase the sample size in terms of those calculations. But I don't think it would be as effective as actually increasing the population size itself, because you'd expect a patient's experience, any individual patient's experience would be highly correlated 1 year to the next. So you want as many different patients in the population as possible. But I also think just from at a practical level, provider organizations aren't going to do well if they have to wait an extended period of time in order to earn the rewards that they in fact have achieved. So if it's a 2-year cycle, for example, it's just hard to imagine those incentives having a real significant impact on provider behavior.
Okay, that was the last question, and I guess we could give a few seconds for anyone else to write in a question. I don't see any, so I think we can wrap up.
Okay. Well, thanks, Linda. And thanks, everybody, again, for taking the time to attend the webinar this afternoon. On the screen, you see my email address as well as Linda's. And if you have any follow-up questions, if you'd like to request a copy of the slides, if you'd like to discuss some issues that you might be facing relating to payment reform, design, performance measurement, value-based purchasing, we'd be very happy to hear from you. But thanks for your time and have a good day.
Thank you. That concludes the webinar. Thanks for your attention.